right, thanks very much, Dr. McClendon. Our next speaker is Ashraf El Naga, who's Associate Professor of Orthopedic Surgery at UCSF, and will be speaking on spinopelvic injury and stabilization.
All right, well, thank you all so much. This is, I think for me, this is the best course of the year, so I thank you for inviting me out. Yeah, so I'll be speaking about spinopelvic injuries and stabilization. So I have no relevant disclosures here. And so to start off, the reason that these injuries sort of matter is the sacrum is responsible for transmitting load from the spine down to our lower extremities. We think of, if you look at the shape of the sacrum, it's pretty much shaped like a keystone that then transmits load to the rest of the arch. And pelvic injuries, there's just a huge variation in the injuries that we see. They're complex. And sort of in the current era, what we see is that, often as spine surgeons, we underestimate the value that we can provide in treating patients with particular injury patterns. And then our colleagues on the, on the orthotrauma side, we sometimes underestimate the utility or the added value and capabilities of MIS spine instrumentation in the treatment of particular injuries. So we're going to go into this a little bit. There are so many different classification schemes. So on the pelvic trauma side, these are the ones that we think about that really focus on pelvic ring stability. But I'll talk a little bit more about sacrum-based classification systems. So we have a number of different ones here that each have a different outcome. So you have the Denis classification that really focuses on the risk of neurologic injury, the Isler classification, which focuses on the stability at the L5-S1 junction, and then our Roy-Camille classification that talks about injuries that have a transverse component. And what we start seeing is, even though we have all these different classification patterns, we can start grouping these injuries into those that are predominantly vertical in nature, or those that have a transverse component. The most comprehensive one is probably the AO spine. So if you want to read up and understand, this one sort of combines all the other classification systems and is pretty comprehensive. But you still see this preserved grouping of vertically oriented patterns and transverse oriented patterns here. So for our vertical, our injuries that have a vertical component, they come in a number of different flavors. So you have these vertical shears where the whole hemipelvis is sheared up. It has, implications for weight bearing. You need to bring the pelvis down to treat it. This vertical fracture can happen in different spots from medial to lateral within the sacrum. And then the injuries with the transverse component, there are different morphologies and that we sort of describe colloquially. And then these are sort of the Roy-Camille classification, which shows the different patterns of kyphosis and translation and shortening. And so while spinopelvic fixation has largely been limited to injuries with a transverse component, the role for our involvement in the treatment of vertically oriented fractures is really still in its infancy, and where we could really move the needle forward. So to talk about each of these specifically, so for the injuries where there's a transverse component in the sacral body, fundamentally the spine is disconnected from the pelvis. And the things that we need to consider here, these are the three factors that we need to consider: the sacral kyphosis that results from this, the neurologic status, and whether or not the rest of the pelvis is in one or two pieces. So this is a sort of a common, a typical pattern for these injuries. So this is a patient with a U-type sacral injury. When I see this image, my first concern is, does this patient have an acute cauda equina type picture, right? You could see that with the translation of the sacrum there, the canal is sort of compromised. A lot of times these patients will be neurologically intact on the motor exam because the S1 nerve roots have already come out. And so you really need to do a rectal exam for both sensation and tone. The kyphosis is, from a mechanical standpoint, the kyphosis is problematic here. So if you acutely change your pelvic incidence, and this is the one thing that changes your pelvic incidence, right? And you tip over by 40 degrees, if this patient heals in this position, in order to keep their head upright, they're going to have to hyperextend by the same amount, which is then problematic. And so here's that same patient pre-injury after our reduction. And what I want to draw your attention to is really just the lumbar lordosis, the compensatory lumbar lordosis, even in the supine position. So you can imagine how this would be exacerbated when the patient is upright and over the course of a lifetime. So what parameters do we accept? We really don't know. So while we can, while there's a number of studies that show that global sagittal alignment after these injuries is correlated with long-term pain and disability, there's still no consensus as to what represents acceptable residual kyphosis. And so we really think about how much we can achieve for a given patient. These injuries, for the high-grade injuries, they typically require an open reduction. But what are sort of the outcomes with this? So this is the study out of Seattle. So for those patients with a deficit, these procedures are really good at restoring, bowel and bladder function. So they're not to be discounted when you need to. But it comes with a huge soft tissue cost, right? So you're unroofing or uncovering a traumatic dural tear in the majority of these injuries. You have secondary wound healing issues, and this is not because of the procedure. It's really a consequence of the injury. Right, so this is the fascial disruption that you see. So you can imagine trying to get, to control a CSF leak in this setting becomes sort of quite the task. So for now switching gears to injuries where the pattern is a little bit more vertical, the things that we think about are what's happening at the joint, whether or not the hemipelvis is translated vertically. What the anatomy is like in the upper sacral segment, because this has implications for the bone that's available for screw placement, and what are weight-bearing goals. So for the first one here, so in the 89, Isler described these different patterns of where the fracture exits relative to the superior articular facet of S1. When the fracture goes more medial, you could potentially disrupt the transfer of load at the lumbosacral junction. So here's a patient where they had a floating superior articular process. This was treated a long time ago with sort of transverse, with our traditional fixation. You could see the fracture there, that facet fragment there. And not surprisingly, this patient went on to develop facetogenic pain requiring a lumbosacral fusion. And so when we see these displaced injuries, a lot of times you'll want to span it and go up to L5 and consider a fusion for the displaced one specifically. So for the anatomic considerations, so this is S1 in the non-dysmorphic pelvis. So on the trauma side, we consider pelvises to either be dysmorphic or non-dysmorphic. And that's just a binary yes or no. Can I fit a transiliac transsacral screw all the way across? So in this patient, I can. In the dysmorphic patient, which on the spine side we sort of refer to as more like they have more of a lumbar size sort of S1. If you try to do that, there's a good chance you're going to knock out the L5 nerve roots bilaterally. So you can't just go to say that this is my structure for the construct I'm going to create for every patient. You really need to look at their underlying anatomy and what's safe. And so these are, all the reasons all the things that we consider in vertical fractures makes, you can make an argument to consider spinopelvic fixation. So our goals of treatment, so of course we want union. We want to decompress the canal if it's compressed and if there's resulting neurologic deficits. And then we want to minimize the complications with prolonged bed rest. So we want to get patients up to prevent deconditioning. So in general, our fixation options, they fall under one of these two categories. And in his talk yesterday, AJ sort of discussed the pros and cons of these. So iliosacral screws is still the mainstay of treatment for the majority of these injuries. It can be done percutaneously. You can see because of the orientation of the screws, you can generate compression across those vertical fracture lines. And then we have our lumbopelvic fixation, which we'll talk about. So how do we do this? Anytime a patient comes in with a problem, it looks complex, but I try to break it down and just ask these 5 questions to develop a plan. Do I need to decompress? Then that's driven by whether or not a patient has any compressive etiology. Do we need to fuse the lumbosacral junction or not? The answer to that depends on whether you have a displaced facet fracture. And then how are you going to instrument? Are you going to use the open technique or the percutaneous technique? And how are you going to reduce it? Are you going to, is the fracture amenable to a closed reduction or does it require a percutaneous or open reduction? So in last year's talk, we really talked about these first 3, so we'll focus on the second 2. So in terms of what are we instrumenting? So the iliac corridor, we're all familiar with putting in iliac bolts, but for the trainees, we're referring to the corridor bone between the PSIS and the anterior inferior iliac spine. Safe placement relies on being able to put the screw so that it's not breached medially, laterally, cranially, or caudally. And there are a couple of different, starting points. But in the trauma setting, we need to keep in mind that the hemipelvis may be mobile. They may be mobile in relationship to one another when you're putting these screws in. So the different options that we have are freehand. So it's radiation free. You're palpating for the greater troche. You don't have any real-time guidance. You need to account for the patient's habitus. There's fluoroscopy. So a lot of times we'll utilize a teardrop. And as I'll show, so the teardrop is a hard view to work under because it's in the way. And then, of course, our navigation with or without assistance. So how do we make this simple? So we just need a safe cylinder of bone. And in order to define the cylinder in space, I need a start point, a medial lateral trajectory, and a cranial-caudal trajectory. Okay. The teardrop gives us a good view of the start point for these. But as you see here, the machine is in the way for where your hands and your instruments need to be. So you can't work under the teardrop. And so on the trauma side, we utilize all these other views as opposed to looking down the cylinder, these other views to guide our medial and lateral trajectory and our cranial-caudal trajectory. So here's the iliac view. So this is how we're looking at the pelvis here. Just en face view of the iliac wing. You can see the white arrowheads show you the PSIS, and you see the AIIS above the joint there. You see the sciatic notch, and really this is the corridor of bone that corresponds with the teardrop. So this guides our cranial and lateral trajectory. In that first image there, you're aiming too distal into the notch. The second image, you're aiming too high towards and you're going to breach medially or cranially. And then the last one is sort of the trajectory that we want to see. And you could see with these images, you could get all the way to the AIAS, which is usually like 110, 120, right? And then this is the other view that guides our medial and lateral trajectory. So what we're doing here is we're taking a view that's just flush with the outer cortex of the ilium. And you could utilize any of these start points. So if you use more of a sacroiliac start point, you're going to be starting medial to the joint, or you can start right over the crest. And again, you sort of are just trying to find the field goals to go down. And you can see here, this is where the boom is in relationship to where your hands, so it's out of the way. You can go back and forth with these images. How do you get these images? So the iliac oblique, you start in an AP and you just roll away until you get this view here. It's pretty straightforward. The obturator inlet, you start with an AP and then you tilt to an inlet view until you see a crisp S1 body. This is actually a really good view to confirm that your S1 screws are bicortical if you try to get bicortical screw fixation. And then you roll over to get your crisp view there. And you could utilize these views even in the setting of other hardware to navigate around them. And here we confirm on our teardrop at the end that our screw is safe. And using fluoroscopy, you get pretty similar screw lengths to navigation. AJ and Monty published this for us earlier this year. But what are some of the limitations? So you really need to be able to clearly visualize the anatomy. In some patients with osteopenia, they have bladder contrast in the setting of trauma or a lot of bowel gas. Sometimes it's difficult to really delineate the sacral foramen, as in these pictures here. And so in this case, sometimes, navigation actually makes it, you can utilize navigation in these settings and it provides some value. And when you're doing flora, you're going between one or two views. So similar to Lionel's concept of this sort of whack-a-mole concept of, it's really difficult to stay steady in one plane and shift to the other. And so with navigation, this just becomes quite a bit easier, as we all know, right? So here's a patient who had a GI stromal tumor, who had a fracture, a pathologic fracture. I couldn't make out the foramen on his fluoroscopy. And really wanted to maximize all the corridors. And so we use navigation to fill up all of his pelvic corridors with screws. You could plan your incisions. So you could see the skin changes there from his prior radiation that you can really try to stay out of to get him back to weight bearing. And what are the limitations of navigation is that you're relying on a projection. So while the navigation may show you this, you don't know whether you've deflected off the SI joint. And you can potentially end up with like a drill in the, in the pelvis. So it's really technique dependent. So you want to use a stiffer drill, really be gentle with your technique, not force the drill down. And so our intraoperative concerns when we go from fluoroscopy to navigation goes from, is this a good fluoroscopic image to, is my navigation accurate? And in trauma, this is even more compromised because anytime you try a reduction maneuver, your navigation is going to be off. And of course, here you want to make sure that your tulips are recessed below the PSIS. Because in the traumatic setting, these are going to become problematic. And so we'll go to just 2 quick case examples. So this is a patient from within the last 2 months, a 20-year-old presented after a multiple story fall, had a pretty significant traumatic head injury, bilateral lower extremity fractures, had this H-type lumbopelvic dissociation with significant translation, a little bit of shortening. As is pretty common, a lot of times our management for these patients is really dependent on the management of their other injuries. He had a significant head injury that required monitoring of his ICPs. We weren't able to get to him for about 10 days. And so you could see in those 10 days, he just continued to intussuscept. So his pelvis, his spine intussuscepted into his pelvis. And now we're short about 2 or 3 centimeters. So how do we tackle this? Is there any possible, you're looking at this, I was like, this is probably going to require an open procedure, but we always try to see if we can achieve anything percutaneously first. And having a low threshold to open, you need to do whatever you can to get an acceptable reduction. But if we can avoid the added soft tissue injury risks with an open procedure, that would be ideal. So what did we do? We took him to the OR once he was stable enough to go. We put in percutaneous screws. So percutaneous iliac bolts, percutaneous screws into L4, so L5 and S1. The S1 screws, you're converging them so that they're bicortical, so you can directly manipulate that fragment there. On one side, I put in an additional L4 screw just so I can, and you'll sort of see why on one side. And then on the side with the L4 screw, attached a temporary rod and secured everything. And I can't overstate the importance of monoaxial screws for this, because as you're doing your reduction, you don't want to lose any of your traction, any of your force through the poly screw interface. And so especially in trauma, the utility of the monoaxial screws is, they actually can be pretty powerful. And then you can, with one side locked between L4, L5, and S1, you can distract against the shank spin, so another sort of proxy for a monoaxial sort of fixation into the pelvis. And then you work to get as much length as you can, put the rod on the other side to secure it, and then you sort of iteratively distract. And here we don't really have a good landmark because the distal sacrum is its own free fragment. You can't rely on that. So we're really trying to get the L4-5 disc up to the level of the iliac crest. Because the 2 hemipelvises were not connected, we put in a transiliac transsacral screw to connect the pelvis in the back. And this is sort of where we ended up. You could see on that 3D picture, you actually see the bicortical nature of the S1 screws, which is the only way to get any meaningful purchase into that comminuted upper sacral segment. So we went from here to here, and this is sort of the final construct. The L4 screw is just for temporary fixation so that we can sort of have some leverage to pull the spine and get our length. So going on to an example of a more vertically oriented fracture. So this was a 35-year-old lady who presented with a polysubstance use, schizophrenia. She presented after a fall with a vertical shear pelvic ring injury. If we draw a line across her L5 end plate, you could see that the hemipelvis on her left side is about 2 centimeters shortened compared to the other side. And because of her social history and her compliance concerns, so traditionally we would fix this with transiliac transsacral screws and tell someone to not be weight bearing. But given her compliance concerns, given her comorbid conditions, we really wanted to load her up and see if we can give her a construct that she can weight bear on immediately. And so what we need to do for this one, it's pretty straightforward. I need to bring the hemipelvis down and then try to correct the internal and external rotation. But the priority is really getting the length on the pelvis, on the hemipelvis. So utilizing our standard sort of traction table that we use for a lot of our lower extremity trauma, you can put in the femoral traction pin, pull, and you can see what's is sort of hidden in the picture is just the use of bolsters. So we have a bolster on that flank. So as we pull, she's not just simply tilting over. We have her contralateral knee, taped down. So we have something to pull against because you have to use a fair amount of force. This was the initial X-ray here, the initial outlet view. You can see the sacral ala is up there, so about 1.5 centimeters shortened. And with progressive traction and muscle relaxation, we can get her down. And then once we get the length aligned, we can put in an external fixator to try to get our rotation correct. And once we're happy with that, we'll secure it with a transiliac transacral screw. I put one in at S2 so I could keep the S1 corridor open. And then after that, we flipped her using the sort of the Jackson frame. So you do this all in one procedure. And then because the pelvis is now reduced, you just drop your screw into S1 into the ilium. And we added an additional S1 iliosacral screw. So this was her final construct. And this was, she was allowed to weight bear immediately. And this is her at 8 weeks where everything is holding. So our the take-home points for this is really from the spine side. We should be an integral member of the team that's treating these pelvic ring injuries. The key is really understanding the injury pattern, the bone that you have available, and planning your reduction. And despite our relatively rudimentary reduction tools, we can still achieve percutaneous reductions in many displaced fractures. But again, you need to have a low threshold to open if you can't achieve an acceptable reduction. So again, we favor percutaneous reductions whenever we can. So thank you.
Maybe I'll start off with a question. Tell us a little bit about your management of the soft tissues with the shear injury you see with these pelvic ring injuries. And how does the minimally invasive approach help with that?
Yeah. So again, you saw that one clinical picture where, we focus on like the bony injury, but the soft tissues are disrupted posteriorly. And so if you have to do an open approach posteriorly, a lot of times that fascial, if you have to open, that fascial disruption isn't in the midline where you want your fascial incision to be. So a lot of times we'll sort of repair that on the way in. So you want everything on this is a case where, the approach, how you do the approach really matters. How you're minimizing electrocautery, you're minimizing any additional fascial degloving because the skin gets its perfusion from the fascia. This is one where there's a lot of attention on the approach because that's going to dictate a good portion and that's where we can attenuate some of the risks that we see afterwards. And then even for our percutaneous cases, those we're pretty diligent about trying to get, even if we're using our stab incisions, just getting a small needle and repairing the fascia in those too, because there may be an underlying CSF leak and our goal is just not to have the CSF make its way out to the skin. So, yeah. Yeah. So it goes back. So if we can, we'll use traction. That patient that I showed, they had bilateral X fixes in. The issue I have with traction is what am I pulling against? So if I'm doing that, I usually will try to have something underneath the shoulders to pull them against. With all of these injuries, you're doing everything you can to try to get a reduction because they're really difficult reductions. And so traction. I used to put people in bilateral femoral traction and tilt them down so I could actually pull against their body weight, muscle relaxation. Yeah. Thank you.